I trained at the Mass General in Boston. I was there for 10 years. I had the opportunity to be in charge of the ECMO program over there for the past 7 years. A year ago, I got tired of the cold, so we moved to Florida, and I spent a year at the Cleveland Clinic when I was in charge of the ECMO program, the Mechanical Circulatory Support Program for Weston and the Florida region. And 5 months ago, I got the call from NCH because they wanted to open and continue to build the Naples Heart Institute. And now I'm in charge of cardiac anesthesia, the cardiovascular ICU, and the ECMO program. I'm happy to be here, and hopefully we can talk a little bit about how to develop an ECMO program. These are my disclosures, and all the images that you're going to be seeing here have been approved by the patients. So what are we talking about ECMO and ECLS? Well, there is in the recent years, we continue to see a lot of different programs and a lot of different hospitals trying to figure out a way that we can open an ECLS program. And all this happens after 2001 with the H1N1 pandemic. If you guys all remember, prior to that, there was not a lot of ECMO going on in adults. The majority of the ECMO was done in children's, to the point that in a lot of big academic centers, pediatric cardiac surgeons were on call to put patients on ECMO. The cardiac surgeons in the early 2000s got no interest in putting adult patients on ECMO because of the higher mortality. So after after the H1N1 and now with COVID, there will continue to be a lot of interest in growing ECLS programs. We have the ability to support patients, as you guys know, for cardiac arrest or severe lung respiratory problems. And having the ability with the technology to put patients on support and send them to a bigger institution is something that is getting a lot of attention from different hospitals. There is more and more data to suggest that formalizing ECMO programs increase survival and decrease mortality. So we're going to be going through all these key elements. And when we think about opening an ECMO program in our institutions, we have to make sure that the hospital administration is on it, because otherwise it's just going to be impossible. We need to have the appropriate equipment, the appropriate resources. And once we have that, we can sit down and focus on getting the indications and contraindications, creating different protocols, trying to figure out who's going to be the physician in charge of this, who's going to be the perfusionist in charge, who's going to be the nurse in charge, trying to come up with a multidisciplinary team that will take care of these critically ill patients. Before we go deep into this, we need to learn and know why do we think about this and when the patients are on cardiogenic shock. There are different definitions and different ways to evaluate these patients. Here you have the shock trial, the AIBP shock, and the guidelines from the European Society, and they all pretty much say the same. Hypotension with high filling pressures, low urine output, higher lactate is when we start to think about shock. But the shock that we see more often is the post-cardiotomy cardiogenic shock. That's where we work. We work in the ICU, we work in the ORs, and historically used to be a mortality close to 80%. And the rationale for this is because we never wanted to leave the patient on ECMO. We were trying to maximize inotropes, maximize pressures, and the patient will leave the OR with an open chest, a balloon pump at the most, and in ridiculous amount of inotropes. And when a few hours after trying to take the patients back, obviously multi-organ failure, these patients were dying. Now we continue to see more and more different presentations, and the idea is to continue to learn how can we avoid these problems. And even though this is something that we don't want to face, and we don't understand why this happens, we know that it could be about rushing the patients without an appropriate evaluation pre-op, prolonging time on the pump, poor myocardial protection, and ongoing ischemia while on pump. This is a very interesting article that shows you that for years we haven't been able to figure it out, the mortality and why are these patients keep dying in front of us on mechanical circulatory support. And this is fascinating because we have to start learning about the different patients. Not every patient is the same. You can have a patient with ischemic cardiomyopathy with a low EF. they live with a cardiac output and a border cardiac index. And then you have a guy that has no major medical problems coming with a heart attack. And this is the different stage of cardiogenic shock from the sky. And I like these slides because it's easy to know when the patients are in extremis, and it's easy to know when the patients are at risk. But trying to figure out and combine your physical exam with your biomedical markers and your hemodynamics to try to take and get these patients prior multi-organ failure. And I think that's a key when we look at these patients. And when you go this further and evaluate this patient with ischemic cardiomyopathy that's living with a cardiac index that is borderline, and you use any type of support and you increase the cardiac output a little bit, they have better mortality than the patient that was otherwise normal with acute myocardial injury. So deciding the device is important. Why? Because unfortunately, we don't have enough organs at this point. We continue to work hard on the transplant world to try to figure it out if we can use more organs. 70% of the organs that are available ended up not being used for X, Y, or C. Now we're using more Hep C. Sooner we're going to be doing more HIV as soon as we get the cure, and we're really close to that. And we'll be able to offer new organs to our patients. But in the meantime, we have to become creative and continue to be and get comfortable about the technology that we have. We don't need to be an expert or a cardiologist of echocardiography to see this patient and this heart that is not moving. This patient had cardiac surgery 12 hours before, now it's in the ICU on maximal amount of pressors and inotropes. And when we look into this heart, we need to figure out why this happened. Why can we figure out a way to avoid this to happen? And think about ECMO even sooner. So what's ECMO and ECLS, extracorporeal life support versus ECMO? I think we do more than that just providing oxygen. We support these patients. And we need to think about ECMO when every time we have a severe acute respiratory failure or acute heart failure, that medical management is not being enough. We're maximizing medical therapy. And then we get the call to put these patients on support. As we all know, VA ECMO, we get blood out of the system, we oxygenate, we remove CO2, and we put it back. Can be retrograde, can be antegrade, based on where the cannulas are and based on the condition. If we are in the OR and the chest is open, we can do antegrade. If the patients are arrested in the ICU or in the ED, we go through the femoral. There is more and more data now, and this is a great review that came out last year when the mortality is being between 40 and 60%. And it's because we are creating more awareness about recommending our surgeons to put these patients on support before leaving the OR. And that's something that we have to continue to keep in mind. And that's the importance about creating and formalizing an ECMO team. This is more about when we talk about VV ECMO, we get blood out of the system, and we have to have, as you guys know, a pretty decent heart to be able to pump that oxygenated blood back. I don't know if you guys are aware, but Europe is way ahead of us. This is a patient that is being placed on ECMO in the middle of a train station in Paris. And when you look around Europe, Italy, Germany, Paris, and they've been really ahead of us, doing a fascinating work in cannulating patients all over. These are one physician and one perfusionist putting the patients on ECMO. So when we think about ECMO, we have to think about the indications, and it's patients that have low cardiac output, low cardiac index, high CVP, that the pressures really keep going up. You have lactate that is not getting better, or you have unstable arrhythmias. And the sooner we think about mechanical circulatory support for these patients that are in extremis, the better. We have absolute contraindications. If we have obviously a patient that had a stroke or hemorrhagic bleed, or is bleeding pretty badly, or we have moderate to severe AI, obviously is one of the main contraindications for it. So why VA ECMO and why ECMO is important? Well, it can be done quickly. You can assemble different equipments. It can be your CentriMag with your Quadrox. It can be your Biomedicus. It could be your cardio hub, any device that we have in the institution to be able to support these patients. If we are in the OR and we have the chest open, when we have to think about what the problem is. If this is an LV problem, if this is an RV problem, this is a biventricular failure, or if the patients are on severe pulmonary edema. So we can use the same cannulas on the right atrium and the aorta, or if we think that this is going to be a longer issue, we can just put the patients on BiVADs and add an oxygenator. Then the oxygenator can come off. If this is the LV alone, we can have strategies to provide LV support. And when we think about ECMO and we think about formalizing the ECMO team, this is a nice paper that we presented a couple of years ago, trying to think about ECMO as a sport team. The more we think about figuring out a way that we can have a multidisciplinary team to work with us, is the better. And I love this slide because when we developed the formal adult ECMO program at Mass General, we went around and said, well, who's going to be part of the ECMO program? And everyone is saying, yeah, who wants the fleece and a jacket? Yeah, we want a jacket that says ECMO program. And can we put the ECMO program on the side of the arms? Yeah, what about the two sides? Yeah, we want everyone with the big logo, Harvard, ECMO teams. All right, who's going to be on call? And someone is quiet, everyone quiet, right? And those are the challenge for ECMO. We don't get the call at 2 p.m. on a Monday. We get the call on 2 a.m. on a Friday. So in order to, once we think about ECMO and we think about ECLS, we have to figure out the personnel and the coverage. Who's going to be at the bedside? Who's going to be on call? Who's going to be responsible? Who's going to take care of this pump? It's going to be a hybrid model that we have perfusionists, or we're going to train our pulmonary and respiratory teams. So Mass General, we have RT ECMO specialist. Cleveland Clinic, main campus, have nurses that are trained on ECMO. We have different ways to take care of these patients. We have perfusionists at the bedside. So, and it's not only who's going to take care of the pump. The easy thing on ECMO is putting the cannulas. I used to teach my residents and fellows that this is like putting a central line on a steroids. It's just a bigger cannulas, right? You put the cannulas on, you connect the machine, and now what? You have a multidisciplinary team. You need to have someone in the ICU. You need to have a pharmacist. You need to have a nursing staff that are comfortable with these patients. Why? Because the management is quite complex. We have to check about the blood pressure. We got to check about the flows. We got to check about what are the goals. Multiple things that we have to monitor at the same time. We have to prevent other injuries from other organs. We have to figure out the anticoagulation plan. We have to learn all the risk if we're going and sending blood retrograde versus antegrade. We have to figure out if these patients are pulsatile or not. So there are many, many things that are happening with these patients that if we don't formalize and find a way that we get together as a team, we shouldn't be taking care of ECMO patients because the mortality is going to be through the roof. Especially when we are on peripheral VA ECMO. And I always mention this. God didn't design us to get blood from the groin, right? So when you're sending blood from the groin, you create a huge afterload to these hearts. So now the heart is trying to pump against 4 or 5 liters of flow. So we gotta really understand the hemodynamics that happens on while we put these patients on support, trying to figure out how can we avoid these problems, how can we avoid the classic north-south syndrome or Harlequin syndrome. If you see, this is a really cool picture because we're coming with contrast from the groin, and if we have a heart that is ejecting deoxygenated blood from bad lungs, guess what? The most important organ, the brain, is not getting enough oxygenated blood. So all these things that happen, and then is when, we used to get a call. I was sharing this with my colleagues earlier on. We used to get the calls from outside hospitals saying, hey, I have this patient on ECMO that went on ECMO 2 days ago. He's stable, he's off pressors, he's now starting to make urine, he's a young patient. Well, great, and what's a neuro exam? Well, I don't know, I'm the new physician, but I heard that was okay. Well, meaning, can we find out what was a neuro exam? Well, I was told the patient was too unstable to travel because he's on the ECMO pump and he had a balloon or an impeller. Well, if he's too unstable to travel to the CT scan, he's too unstable to travel to my institution. So we have to figure it out. What's a neurological status on these patients before you bring them? Because we can do a lot of things for the heart, and that's why I'm not a neurosurgeon or a neurologist, because I don't understand the brain, but the heart is easy. It's a pump with 4 valves, and we can figure out what to do with the heart. We can do a lot of things for the lungs, and the lungs usually get better. We can do a lot of things for the kidneys, and if not, we can do a heart-kidney transplant, but the brain can do anything. So it is imperative that we figure it out if we're going to be a receiving ECMO program. What's a neurological exam? And if not, make sure that you get a CT scan to see that you don't have a huge stroke. So another important topic is education and training, and figure it out how are we going to be doing continuous education for this team that we're putting. And one of the challenges is volume. And the numbers, the data is very clear. These patients do better in institutions that have experience, because if you have 1 ECMO every 3 months, your staff is not going to get comfortable. You're going to have a lot of issues, so volume is pretty important. So if you don't have the volume, you have to be doing constant education about with your staff, the cannulation that we're going to use, what are going to be the strategies, creating protocols. It's important that we have some sort of support for education and training. That is something that nowadays, with us being short-staffed, you try to come up and put a lecture together, and turns out that the nurses or the team cannot come because they are short in the ICU. So this is something that we as a group have to really think of and push for the education and training once we decide to build an ECMO program. Protocols are very important. You can use the protocols from the ELSO that are really good, but more importantly is to try to develop protocols that fit your institution. Trying to figure it out, get consensus from your team, with your ICU physician, with your perfusion, with your nurses, trying to find out how many, what type of patients are we going to receive. Are we going to be able to just help patients on VV ECMO, or can we do VA ECMO, or can we do both? Standardizing care, trying to figure out what are the standards for anticoagulation. So for instance, I don't know if you guys remember, probably 6, 7 years ago was a national shortage of heparin around the country, right? And for us in New England was really bad to the point that we were just using heparin exclusively for cardiac surgery. Every patient was, even on the floor, was getting Lovenox for DVT prophylaxis. We were canceling vascular surgeries. It was really bad. There was really was an infection of pigs in China, and as you know, the heparin used to come from the Scandinavian countries. Now, for the past 20 years, it's been coming from China. So the quality of the heparin may be a little bit different. So I transitioned 6, 7 years ago all my patients to Bible, and the amount of the stability of the anticoagulation and the amount of bleeding decreased significantly. So I use it and I recommend it as a standard of care. There is multiple and now reports showing that either Bible or Gatroban can be used safely for your ECMO patients. So trying to standardize as a team what's going to be the best anticoagulation strategy for your patients, what's going to be the transfusion protocol. When are we going to transfuse? What type of products are we going to use? And more importantly, how are we going to get these patients off? Are we going to be able to win, or are we going to be just being a program, just putting the patients on and sending them out? So having that standardized is quite important. When we talk about putting the patients on, being organized and do things the same way all the time. For VA ECMO, this is what we're going to use based on the height and weight of the patient, decide what type of cannulas, always trying to use the ultrasound, always using the same technique, and teaching your residents and fellows that are going to be there in the middle of the night to work on the same equipment is imperative. Having steps on cannulation for emergencies and is always important, and having a checklist to make sure that your clinician or whoever is putting the patients on, we do it routinely and we do the same thing. This is something that I did a couple years ago, last year, and I did it also at the Cleveland Clinic. Once the program started getting busier, you don't have the luxury to have cardiac scrub nurses with you when you're putting these patients on. So what we did on the ECMO car is we had a bag with all the important things that we needed for ECLS. This is now the next step, right? You have a patient in the ER getting CPR, and you're going to put the patients on, or you have a patient in the hospital quite sick that you need to put on ECMO sooner than later. If you don't have your cardiac group helping you, we put dots with numbers on that bag, prepping, drepping, access, dilators, different wires, and cannulas, and these really help us decrease the timing, because I'm just, as a physician, I'm just thinking about access, and you guys as a perfusionist are trying to get the equipment together, but sometimes we don't have perfusionists in-house, so we have to wait a half hour, 40 minutes for you guys to come. When the patients are coding, we may not have the luxury of waiting those 40 minutes. So once you elevate and go to the next step, trying to figure out a way that you can have a setup system that anyone can help your physician to put or at least to start the process to get access, it will decrease significantly the timings, and it will increase the survival of your patient. So this is something that we created a couple years ago, is standardized in multiple institutions now, just to try to make it easy, because as you can imagine, you see the ECMO car and you see 50 doors there, and you don't know what's where. So I think this is a good trick, especially for you guys, to have everything in just one area. It's also important that before transport, especially if we're putting these patients in the ICU and we're going from the ICU to the OR, or from the ER, or in the MICI, or in the cath lab, just to make sure that where the cannulas are. There have been a lot of case reports about decannulation on transport. So we have to make sure that we secure these cannulas appropriately, and we need to make sure that the cannulas are in the right position before we move on. When we talk about equipment and transport, this is another key element that we have to figure out with our institution, with our leadership. What devices are we going to get? What pumps are we going to buy? What oxygenators are we getting? The referrals of these patients, who's going to take that call? If it's going to be an intensivist that is going to take the call, where these patients are going to go? It's really difficult to have patients on different locations, especially for adults. In my previous institution, we had NICU, and NICU have ECMO, and PICU have ECMO, and MICU have ECMO, and the cardiothoracic ICU have ECMO, and the CCU have ECMO. So you have 5 different locations, it's just a mess. Unfortunately, we cannot combine NICU, PICU, and MICU, but you could potentially combine all your adult ECMO in just one unit. And I don't do NICU and MICU, but I can tell you that for all my adult ECMO, I try to put them on the same location. It's just easier for staffing. It's just easier to train your nurses, and it's easier to train also your intensivists. So it is important to recognize that, because even though we have different ICUs with different mentalities, and maybe you can have an expert in pulmonary physiology and pulmonary critical care physician, ECMO is a different animal, and we're putting these patients on support to try to give a chance to these organs to see if they recover. So the focus should be on lung protective strategy or heart protective strategy, and taking care of the patients and taking care of the pump. So if you have 5 different locations, then that means that you need 5 different perfusionists. You need double the size of your program and double the size of your staff. So trying to start, especially for an adult program, on the same place that the patients are going to be on the same ICU, is just going to be easier. When we talk about developing a program, we have to make sure that we evaluate this program. And how do we monitor? We sit down together, we talk about issues, challenge, last cases. We evaluate, and we hear from every member of the team about experience or challenge, or what could have done differently. In the ongoing evaluation that is crucial for the success, you need to know equipment challenge. So for instance, one of the challenges that we have, and multiple places have right now, is the size of the elevators. So if the elevators are too small, you have to figure out what type of equipment are you going to get. There are multiple case reports of patients being stuck on an elevator with an ECMO program, with an ECMO patient. So understanding and evaluating your program, it will make you try to make plans to avoid these issues, right? So, and again, going back to the first slide that I have, because it's important, is when you are developing your ECMO program, and when you are developing and making the plan to say, okay, we're seeing a lot of these patients, can we keep them? We cannot do it by ourselves. The way that, if we're going to open an ECMO program, and the way that we always recommend to do is try to figure out what your patient population. Are you seeing more heart failure patients, or are you seeing more patients with respiratory problems? Even prior to COVID, the data wasn't clear about what was better between a good mechanical strategy about keeping these patients on 4 to 6 cc per kilo on the ventilator and proning them, and actually a lot of centers were able to get away from VV ECMO and trying to keep these patients paralyzed, sedated, with lung protective strategies. versus putting them on ECMO. I am biased. I think if you have these patients with severe respiratory failure, you can put them on ECMO, you can wake them up, you can work on physical therapy, and you can wait for these lungs to get better. That's my bias, and I've seen it multiple times. But the data before COVID was really clear, and was really mixed about similar morbidity and mortality. And even with COVID at the beginning, we didn't know the timing to put them on, and the mortality was not as we expected with H1N1. So it is imperative that we have inclusion and exclusion criteria. You cannot be putting just patients right and left on ECMO because the mortality is going to be through the roof. So we have to learn how to say no to some of these patients. And VA is different than VV. If you're going to open an ECMO program, but you don't have transplant capabilities, you should try to connect with another hospital in the region and trying to say, hey, listen, I'm going to open an ECMO program. We're going to try to support our patients, but if they cannot come off in a couple of days, can I send the patients to your institution? To trying to pair up with a transplant center or a center that have experience on ECMO is also important, because I'm sorry, that's going to be a key on these patients. And creating policies and procedures, trying to do things the same way is just going to decrease the chances of complications. Having a team that is constantly evaluating these patients is important. When in my two previous institutions, we were rounding the same team every day on the ECMO programs, on the ECMO patients. And that could be quite of a challenge when you have a group of intensivists. There are 15 intensivists, right? So they rotate every week, and they don't come back in another 10 weeks to the ICU. So for me, it's imperative that if we open a program, have to be the same group of clinicians and physicians trying to round on these patients. Communicating with the families is quite important too. One of the things that I don't think we do a good job is constantly communication with the family. And I think especially when we put these patients on ECMO with a high mortality, that's going to be something that we have to emphasize as we open the ECMO program. When and how are we going to talk to these families? And that's part of the multidisciplinary ECMO team discussions. We had a support group that was done through the palliative team. I really hate the term palliative, because even though they do a lot of good things for the patients, the families will go and then Google palliative and it's end of life. So in one area you're saying, we're doing everything we can to help this your family member, and then on the other side you have a palliative team trying to talk to them. So what we did in my two previous institutions is we used the same group of clinicians, we just changed the name. And that increased significantly the patient satisfaction. So that's important. You cannot be putting these patients on ECMO and then getting the palliative team, and then the families are going to think that they just end of life. So it's just about perception. That was 4 or 5 years, probably more, like 8 years ago, one of the key parts of patient satisfaction. As you know, the hospitals are really driven by trying to figure out the way that we can improve patient satisfaction and communication with the families. And that's something that communication and talking to them and explaining what we're doing every day is important. So just to summarize the development of the team, there is more and more data that suggests that if you formalize an ECMO team and you have a group of physicians and clinicians taking care of these patients and they get the appropriate training, you can definitely improve survival. You have to have a champion group of clinicians and physicians that don't mind to come back and be on call at 2 in the morning and to come and take care of these patients, and that's imperative. And we have to be consistent with the training. So that will be my message to end. So thank you very much.